So here we have our last mini medical school limerick challenge. Now one of these is hard, a couple of these are hard. So this goes to lecture 5. Four frail patients who soon might be dead. Dr. Rogers' heart catheters thread. A new valve to install, or an MI forestall. Obviating of surgery. Again? You guys are just way too smart, but I didn't hear a ton of voices this time, so they're getting harder. Okay. FDR made of Eleanor wife in an era of depression and strife. Our great country did serve this fine lady with nerve, named the illness that ended her. Okay, now, which of these was the illness that ended her life? All those for A, raise your hand. B, cancer. C, heart attack. Couple. D, tuberculosis. Okay, so bonus point, shout it out. What was the immediate cause? I mean, tuberculosis, at age 78, tuberculosis had spread into her bone marrow, and so she had a condition called Wow. We're going to have to create the AOA Honor Society for mini medical schools. You'll all be in it. Okay, bonus link, and then we'll move on to our first speaker. At the end of this class, you will leave, but we hope that you'll always believe that the mini med school has armed you with a tool from your doctor's good care to achieve is also acceptable. All right, very good. So a hand for the brightest mini medical school class yet. Dr. Ladson Hinton is a professor of psychiatry at UC Davis, and one of the most important things about Dr. Hinton, as far as I'm concerned, is that he's an avid cyclist. We've met, at Steady Eddie's Cafe in Winters, but he's also, besides being an avid cyclist, he's a national expert on the cultural aspects of geriatric mental health. He's been an organizer and speaker at what is your Latino mini medical?
The Spanish mini medical school.
At the Spanish mini medical school, which was inspired by this mini medical school. And he's an expert on the relationship between Alzheimer's disease and depression, late life depression. He's currently the principal investigator of a big National Institute of Mental Health study entitled Reducing Disparities in Depression for Ethnically Diverse Older Men. And he directs the education core of the UC Davis Alzheimer's Disease Center, which is funded by the National Institute on Aging. So we're very excited to have Dr. Hinton, and I will let him take the podium. So welcome, Dr. Hinton.
Thank you very much, Dr. Hirsch, and thanks to all of you. You know, actually, when I spoke about 6 or 7 years ago, I also spoke about clinical depression. And I changed the lecture up this time just in case there was somebody out there who had seen my previous lecture, but it looks like that's not going to be a problem today. Actually, I'm excited about giving today's lecture because it really touches on two subjects that are very close to my heart in two different ways, both in my clinical work and also in my research. So the research I do is, part of it is focused on geriatric depression. As Dr. Hirsch mentioned, I've got an ongoing project now that's focused on depression in older men. And so that's been an active area of investigation for me. I've also done quite a bit of research around Alzheimer's disease, particularly as it affects caregivers in ethnically diverse populations, and also about how we can better deliver care to people with Alzheimer's disease and their families in primary care. But these topics also are very close to my heart because I do, in addition to my academic work, I work 1 day a week at the VA in McClellan, and I do clinical work to older vets. And so these issues are very, are right up there in terms of the vets that I see, the older vets, issues having to do with depression and also with Alzheimer's disease. So just out of curiosity, how many people out in the audience feel comfortable in sharing whether or not they have personally been affected, not they themselves, but a family member or friend, with significant clinical depression? How many people? So quite a few. And how about Alzheimer's disease? The same. So these are also topics that I think probably almost everyone in the room has some personal experience with. And so hopefully this will be, of use to you. So today, basically, my talk's going to be oriented around these 4 themes or connections between Alzheimer's and depression. And of course, Alzheimer's disease is one type of dementia. So this is really about more broadly dementia and depression. And first, I'm going to be talking about how depression is the data, the evidence that we have that depression may be a risk factor for the development of dementia. The second is that cognitive impairment can be a symptom of depression. The third sort of connection between these two concepts is that depression is frequent in people with Alzheimer's disease and dementia. And finally, depression is a very common symptom and a condition in caregivers to people who have Alzheimer's disease. And so those are the 4 connections, and we'll explore those today and definitely leave some time for questions at the end. So when I give this lecture, I give a lecture like this to the medical students at UC Davis, I often begin with a case, like from the real world, to kind of bring this together. So I'm going to read through this unless, actually, when I give this to medical students, I ask for a volunteer from the audience to read the case. Is there any volunteers? Yeah, so I guess I'll do that. So Dr. Smith is a 68-year-old married man with a history of anxiety who works in the mental health field and is the caregiver to his wife who has Alzheimer's disease. So he's seeking help from his primary care physician for clouded thinking and feeling overwhelmed with caregiving responsibilities. He describes a 6-month history of difficulties with word finding, recent memory, and ability to organize. He also feels more easily tired during the day. He's making more errors in bookkeeping, writing, and occasionally missing appointments. He continues to live independently and to work full-time, but feels that he's slipping and worries that he may have Alzheimer's disease. He endorses depressed mood and says he feels more irritable. He's the primary caregiver to his wife who has Alzheimer's disease. His past medical history is significant for sleep difficulties, fibromyalgia, prior episodes of major depression, in addition to his anxiety, and hypertension. He's on melatonin, Elavil, and Paxil, and as well as amlodipine. He's a neatly dressed gentleman. He's very cooperative. His speech has an anxious prosody, probably a little bit like mine right now in front of this big audience, so a little on the anxious side. And it's also notable for some word-finding difficulties, which I certainly hope I don't have today. His mood was worried. He didn't have any psychotic symptoms, hallucinations, or delusions. He did endorse some passive suicidal ideation. He's very worried about having Alzheimer's disease. He had good insight. He scored 27 out of 30 on the mental mini status exam, missing 2 items for short-term recall and 1 for calculations. And his primary care doctor actually diagnosed him with mild cognitive impairment, possibly early dementia. So actually my question for you is, this is not a test, but who can see connections between Alzheimer's and sort of depression in this gentleman? Anybody want to raise their hand? And yeah, right here in the front.
Yeah, I think certainly there's a lot of stress put on this gentleman because his wife's condition and being the primary caregiver.
That's right. So he's the primary caregiver to someone who has Alzheimer's disease, and that certainly is one of those connections that we'll be talking more about. So excellent. So you get an A on the exam for today. Any other connections that we see here? Yes, right up here.
Irritability, difficulty sleeping. He says that he has depressive moods.
That's right. So, he could be depressed, and that's the cause of his cognitive symptoms. So so you also get an A. And 2 more A's to give out, if anybody else wants to guess. Yes, right here in the front row.
He's also worried because being a doctor, he knows that he's declining and worrying for the wife.
So his worry for the wife, so the caregiving. And he's declining, so I guess we could say that also maybe he has Alzheimer's, and his depression is actually a manifestation of that underlying process. Any other? Fine, those are 3 good. Yes, right here in the front row.
Being in the medical field, he's also aware of what Alzheimer's is, more than most.
Very aware. So that's so this is a case. I don't want to discuss it in more depth right now, but we're going to come back to it at the very end. And I want you to keep this in mind as we go through the rest of the talk today. And actually, I can tell you how this situation ended up. I've changed a few of the details, but I'll tell you what happened in the end. Yes, one more thought here. Gentlemen, is that a San Francisco 49ers cap? Okay. Yeah, I'm really sad about the Super Bowl, by the way. That was a bad outcome. But
being suicidal is depressive.
That's right, absolutely. So suicidal ideation can be an important symptom of depression, especially in older men. And we may talk a little bit more about gender and depression later on. So I'm going to go ahead and move through this. I know everybody's very engaged by the case, which I was hoping you would be. But I want to move on to sort of the first, which is depression as a risk factor for dementia. So how many people here have heard this, that depression may be a risk factor for cognitive decline, transition into mild cognitive impairment, and dementia? So there's actually a sort of an emerging literature on this, and we now consider the fact that depression may be a potentially modifiable risk factor for the development of Alzheimer's disease and dementia. And this comes from observational studies. And this is actually a list of potentially modifiable risk factors from Alzheimer's disease that was published in The Lancet back in 2011 and mentions vascular risk factors, smoking, physical inactivity, depression, cognitive inactivity, lack of social engagement, and low educational attainment. So these come from observational studies. I think actually the strongest data out there right now is probably for vascular risk factors, physical inactivity, and also low education. But there's also a growing literature on depression. And so that literature comes from a number of longitudinal as well as cross-sectional studies. And I would say most, but not all of them, show an association between having depressive symptoms when you're not cognitively impaired and future trajectories of cognitive decline. So depression may be depressive symptoms, or clinical depression may be a risk factor for cognitive decline. So unfortunately, we don't have any intervention studies yet. And so the caveat here is that often in the observational studies, we find an association between two things, even if those are longitudinal. But when it goes to intervention studies, we don't actually find that modifying that risk factor actually decreases the risk of that adverse outcome. But there are a number of studies that are in the works. If you go to NIH to look at their database of funded grants, you'll be seeing a lot of data, I think, on this over the next 5 to 10 years. So stay tuned. There's also some emerging data from different groups, again, observational, that chronic stress may be linked to a risk of transition from being cognitively normal to having mild cognitive impairment. How many people were here for Dr. Mungus's lecture a couple of weeks back? Did he talk about mild cognitive impairment? So you all know what that is. Basically thought to be a state in which essentially someone's cognition is not normal, and they may have a little bit of a slight, subtle degree of functional impairment. But for the most part, they're functioning independently, and they're at increased risk for developing dementia. And so that's some of the scientific evidence about the association between depression and future risk of Alzheimer's disease. So I think it's sort of interesting to think about some of the possible mechanisms for this. And this really is more in the land of sort of speculation, but I think there are a number of possible ways in which these two conditions could be connected, that depression could lead to cognitive decline in Alzheimer's. First, if you think, and many of you said that you had a personal experience with depression of some sort, and if you think about your own experience or that of a family member or friend, think about how depression affects you. So often people who are depressed become more socially withdrawn. So they isolate themselves. And so they really are becoming more withdrawn from social interaction, which is a powerful source of cognitive stimulation. People who are depressed, often their lifestyle changes in ways that can be kind of harmful in terms of their health. So their diet may get worse. They may not exercise. Sleep. They may become more sleep deprived or sleep too much. I think the most common thing I see in clinical work is that not enough sleep. And there actually is some growing sort of interesting data on the impact of sleep deprivation and poor quality sleep on risk of cognitive decline. And finally, people who are depressed tend not to manage their health conditions as well as people who aren't depressed. So if they have diabetes, maybe they're not as good about sort of taking their insulin on time or adhering to a diet that's healthy for them, that's best for their diabetes. So chronic illness self-management is not optimal in people who have depression. So these are all things that might also feed into sort of a risk of cognitive decline. I think there's also the possibility that depression may have a direct sort of toxic effect on the brain, especially if it's severe and longer acting. And so some of those regions that are really important for short-term memory, for example, like the hippocampus, which I'm sure Dr. Mungus talked about when he was here a couple of weeks ago, that those may also be adversely affected by depression because of dysregulation and increased corticosteroids sort of in the system that negatively affect those areas of the brain that subserve short-term memory. And so we also talked, and something I'll come back to a little bit later, is this whole notion that sometimes depression might be the leading edge of degenerative brain disease. So the studies that we have of Alzheimer's show that changes in the brain, for example, that are associated with Alzheimer's, plaques and tangles, they don't begin accumulating at the age of 60 or 65 or 70. They're actually in the brain in people at a much earlier age. So there are pathological processes that are going on in the brain that eventually lead in a certain number of people to the development of mild cognitive impairment and dementia. And some of those pathological changes in the brain may also lead to behavioral and mood symptoms. So depression can be the leading edge of, or sort of the prodrome of dementia. And of course, there are other possible connections as well, genetics, medications, et cetera. So I think there's a lot of reason to believe that this story about depression as a risk factor for Alzheimer's will play out in some important ways over the coming decades. So let's move on now to the second connection, which is cognitive impairment as a symptom of depression. And so, I'm sure that Dr. Hirsch remembers from way back the concept of pseudodementia. How many people here are sort of familiar with that concept? So in clinical psychiatry, we used to think of this as it's basically that you have somebody who comes in who has a dementia syndrome, and really what they've got underlying that is depression. And so depression is actually the cause of their cognitive impairment. And we do see this clinically. And so another way to sort of think about this is that if you think about the symptoms of depression, and we'll go over them in just a little bit, but there are a number of them, and problems with concentration, which can also make people's memory not work quite as well, is one of the symptoms of depression. So depression can kind of lead to cognitive symptoms. And what we find is that memory complaints are also very common in people who are depressed. So if we think about Dr. Smith in the case, he was very worried, as somebody in the audience pointed out, about Alzheimer's disease. And so maybe that worry about having Alzheimer's is sort of part and parcel, really, of his depression, because he's aware that maybe his memory is not as good, but that's a symptom of his depression, as opposed to a product of an underlying degenerative brain disease. In clinical practice, sometimes depression-related cognitive impairment or dementia can be difficult to distinguish between Alzheimer's. And sometimes things like neuropsychological testing can be quite helpful. Clinically, often what we do in these cases, too, is we sort of assume really the best scenario, which is that really most of the cognitive impairment, or all of it, is actually due to depression. And we try to aggressively treat the depression and, of course, do other things to keep that person safe and talk to the caregiver, et cetera. But then we hope that that depression remits. And I've seen a number of cases in which this has actually occurred. And so you aggressively treat the depression, and then the cognitive impairment actually improves substantially. So these are some of the symptoms of depression. I don't know if you all are, this is sort of DSM-4. Actually, unfortunately, this is going to become outdated in about 2 months, because DSM-5 will be coming out in May. And so inevitably some of these symptoms will change. But this is sort of will give you a good sense of the basic sort of clinical syndrome or clinical diagnosis of major depression. And so what you see on one side, on the left, are all the core symptoms of depression. Depressed mood, loss of interest, changes in appetite, changes in sleep, feeling worthless or guilty, suicidal thoughts, problems with concentration, being agitated or slowed down psychomotorically, and poor energy. And I'll just add that actually often when we do studies and talk with older men, one of their most prominent complaints when they're depressed is that they feel useless, this sense of uselessness and worthlessness. Additional features of the clinical diagnosis of depression that, it usually, if it's clinically significant, it does make it more difficult for people to function. They may be functioning, but it may be much more of an effort. Or if the depression is really severe, they're unable to function. It lasts for a while, 2 weeks, often much longer. In many cases, clinical depression can be a chronic condition that people have to deal with for years. It's usually present on most days and most of the time. So it's not sort of a fleeting sort of feeling that comes over one for 5 or 10 minutes each day. And this is really kind of a pervasive disturbance of mood that occurs on most days for most of the day. And it's not due to bereavement. So it's not simply the response to the loss of a loved one, within the past several weeks or month or even within a couple of months. And there are a number of different types of clinical depression, major depression, bipolar disorder, et cetera. I'm not going to sort of dwell too much on these. The only thing that I'll mention is that clinically, what I have often seen is a combination of what is often initially identified as anxiety and depression. And so they'll say, gosh, there's this person that I have who has this depression that's really difficult to treat, and they're very anxious as well. And certainly in a subset of those patients, what they actually have is a form of bipolar disorder. And so they're in a kind of activated, what we call a mixed state. And that's really important to recognize because treatment of bipolar disorder is different from the treatment of depression. That really, if you have bipolar disorder and you're in an activated state, you want to be on a mood stabilizing agent, possibly with, in addition, being on an antidepressant. But an important thing to keep in mind when you see that combination of depression and anxiety. So this is one of my favorite slides, the many faces of depression. When I was getting this talk ready, I thought maybe I should actually go to Google Images and pull off images of all these different sorts of symptoms. But actually, this is to make a really, really important point. And the point is that I think often, for the lay public, but to some extent for the medical community as well, I think this idea of clinical depression is still associated with the idea that people are sad or feeling down, and that's the presentation of depression. And so this slide is to make the point that there are a lot of different ways in which the clinical condition of depression gets manifested. And so some of the vets I see at the VA, to go back to this example, men, I'll say, do you feel down or depressed? They say, no. Do you feel useless? Oh, yes, I feel very useless. Sometimes so much so that I think about taking my own life. And they have lots of other symptoms of depression. So don't hang your hat on just depressed mood, feeling down, sad, crying. Often that's a part of depression, but there are a lot of people who experience it in other ways. Irritability, delayed rehabilitation when I worked in nursing homes. Actually, I'd get there would be clients who would be referred to me, and they'd say, well, gosh, we just can't, this person is just not getting motivated to do their rehabilitation after stroke or, a hip fracture, kind of getting back to being more functional. And what sort of was underlying that was really depression, not feeling motivated, not having the energy. So be aware of these many different phases of depression. So what triggers depression? Genetics, is that the main cause? Actually the main cause is stressful life events. And so that's why so many of us are vulnerable to depression, right? Because life is stressful. And, some people who have stressful life events will develop depression. And so that's a big part of the cause of depression. There are a number of other things. Medical illnesses and medications are really important causes of potential causes of depression, things that we always look for clinically. Substance abuse history, as well as, in a smaller percentage of people, it may be really fundamentally more of a hereditary thing. But stressful life events are really the big cause. And I think this is really important clinically because I guess the way I like to think about it is in terms of a vignette. Many, many years ago, a woman I saw who was actually Vietnamese and very depressed. And she kept coming into me and asking me, talking to me about all her depressive symptoms through an interpreter, because at that time I didn't speak any Vietnamese. I do speak a little bit now. But, and I kept giving her medications and trying to be a bit supportive, and she just didn't get better. I mean, weeks went by and she didn't get better. And it was only about 6 months into treatment that we realized that her husband was severely beating her at home. And there were cultural reasons for, to some extent, for her not sort of telling me about those symptoms. But the important point here is that you could give her all the antidepressants in the world and you were not going to treat that depression. What you really had to do is get to the root cause, which is this terrible situation she was in at home. And so often, I think that's a really, really important part of, of depression treatment, either sort of getting rid of that stressor or giving people skills so they're better able to deal with stressful and difficult things that happen to them in their lives. So I'm going to move on to number 3. Depression is being common in people with Alzheimer's disease. So this is also something that I'm acutely aware of because I've done a lot of research with caregivers of people who have Alzheimer's disease and actually looking at all the different behavioral symptoms that they see in the person with Alzheimer's. And depression is a very, very common symptom. It also, in studies that have been done, if you have somebody who has Alzheimer's disease and has symptoms of depression, they're more functionally impaired than someone who has Alzheimer's disease and doesn't have depression, even at sort of a similar level of cognitive impairment. So depression in somebody with Alzheimer's actually contributes to their degree of disability and functional disability. It can be very, very stressful to caregivers. If you look at the association of sort of different aspects of caregiving for somebody with dementia. So think about the qualities or characteristics of somebody with Alzheimer's, their degree of cognitive impairment, their degree of functional impairment. The thing that's most strongly associated with caregiver depression is behavioral symptoms like depression in the person that they're caring for. That's what caregivers talk about sort of over and over again in a lot of the clinical work that I do. And so in people with Alzheimer's disease, depressive symptoms are very common. I'll show you a slide in a couple of minutes that illustrates that. And there are a number of different ways in which these two things may be sort of related. One is that in people with Alzheimer's disease, as I mentioned earlier, pathological changes in the brain, certain key areas of the brain may actually trigger a mood disorder. Also, sometimes depression and other behavioral problems in people with dementia can be their way of expressing distress due to some social or environmental change or stressor. So just like people who aren't cognitively impaired who develop depressive symptoms as a result of a psychosocial stressor, people with Alzheimer's disease can do the same thing. Now, what they're not going to be able to do often is make that connection, right? Many of us, if we were depressed, we might say, well, I'm depressed, but I'm pretty sure it's because, I lost my job that I'd had for, 20 years, a month ago, and it's really tough to deal with that. I just feel really down. Somebody with Alzheimer's is not going to be able to make that connection because often they have difficulty putting their thoughts and feelings into words or even sort of being aware. They're aware on one level, but cognitively they can't communicate it or even recognize it in the same way that other people who are unaffected by Alzheimer's can. So I always think about these behavioral changes in people with Alzheimer's disease, whether it's depression or something else, as really sometimes being their idiom of distress, their way of telling us that they're distressed because of something that's going on either in their interpersonal world or their environmental world. Something that, the case that I mentioned earlier, the guy, Dr. Smith, who said that he was worried that he had Alzheimer's disease. Let's say that he does have Alzheimer's disease. Now, often, in people who do have Alzheimer's disease, there's a lot of variability in their degree of insight, what we call in sort of neurology and psychiatry anosognosia. So sometimes in people with Alzheimer's disease, there's something about the way in which the disease affects the brain that makes people unaware of their sort of illness or of their symptoms. And so you can see somebody who has terrible short-term memory, and you ask them, how's your memory today, Mr. Jones? And Mr. Jones will say, oh, just fine, no problems, not bad at all. It's not because Mr. Jones is actually trying to cover for his symptoms. He really doesn't have an awareness of his own degree of memory impairment. But when people are aware that their memory is slipping and that they are developing Alzheimer's disease, that can clinically be a very difficult thing. Both for the clinician and certainly for the patient. And so awareness of cognitive decline can trigger depressive symptoms in some people who have Alzheimer's disease. And then also, we can have medications, et cetera, medical problems in people with Alzheimer's that also lead to the development of depression. And so I've got a slide that I think Dr. McLeod gave me years ago. It's one of my favorites. He's got, maybe you all have seen it. It's actually it's a picture of two people on horses, and you can't see their faces. And it says, Alzheimer's never rides alone. And I love that. But I really love that because I think there's a tendency clinically, at least, and maybe from sort of a lay perspective as well, when someone has Alzheimer's disease, whatever they're experiencing, if it's functional decline, we attribute it to the underlying disease itself. And we don't consider that there may be other factors that are going on that we can actually sort of tune up or treat that actually will improve. And it's not going to take away the Alzheimer's, but it may tune them up in ways that improve their quality of life. So I always try to emphasize that to the medical students. So that's that last point. Evaluate, don't assume it's brain disease. So this is neuropsychiatric symptoms in elderly with dementia across 3 different epidemiologic studies. And it's a fairly busy slide, but if you look along the bottom, you see depression, irritability, anxiety, aggression, apathy, disinhibition, hallucinations, delusions, motoric abnormalities, and excessive elation. So these are the symptoms that caregivers are reporting in the person with dementia. And these are very large epidemiologic studies, community-based epidemiologic studies. One is the SALSA, the Sacramento Area Latino Study on Aging, the Cardiovascular Health Study, and the Cache County Study. Thousands and thousands of people in the community. And so I think the upshot here is that things like depression and irritability, aggression, et cetera, these are very commonly reported in people who have Alzheimer's disease. So, it's actually interesting. I think when the new criteria in DSM-5 come out for dementia, I think they're going to reflect the importance of these behavioral changes in people with Alzheimer's disease. That sort of behavioral change, personality or behavioral change from some prior baseline will actually be one of the core criteria for Alzheimer's disease or possible symptoms, along with cognitive changes. So really you could consider these to be, almost as common as cognitive symptoms in people with Alzheimer's. So really sort of a core aspect of the condition. So what about the drug treatment of depression and Alzheimer's? If I had given this talk about 10 years ago, maybe 9 years ago, I would have actually been pretty enthusiastic about medications. Hey, looks like antidepressants may work for depression in people who have Alzheimer's disease. Well, unfortunately, those were the early studies, and once we got more data in, really the data is not very good at all. The data that we have suggests that antidepressants don't look really to be much better than placebo for treatment of depressive symptoms in people who have Alzheimer's disease. And so I think the upshot of this for the field is that we really need to think much more carefully about different non-pharmacologic treatments for depression in people who have Alzheimer's disease. Actually, there are a number of people. Linda Terry, who's up at the University of Washington, has developed a non-pharmacologic approach that involves a focus on pleasurable events. So trying to create time during the day when the caregiver and the care recipient, the person who has Alzheimer's, who's experiencing depression, when they together can do something that they both find or that has been pleasurable for them in the past. So I'm not going to go into that in sort of detail, but the important point here is really to try to find, maybe exercise, maybe trying to normalize sleep in some way through exercise, or just exercise itself might help depressive symptoms in people who have Alzheimer's. We find that, in selected patients, antidepressants still, clinically, I use them sometimes in people who have Alzheimer's who have depressive symptoms. And there are some patients who seem to respond. Certainly, if somebody has a prior history of clinical depression and then is depressed again after they develop Alzheimer's, that would be an important time to use, maybe to try antidepressants, particularly if they've responded to them in the past. But non-pharmacologic treatments, and again, this is true not only for treatment of depression in people who have Alzheimer's disease, but I think in terms of just thinking about behavioral problems in people with Alzheimer's disease, that really the field is moving much more towards non-pharmacologic treatments or sometimes to the combination of non-pharmacologic approaches and possibly medications as well if the symptoms are quite severe. What about selective serotonin reuptake inhibitors in the elderly with Alzheimer's disease or the elderly in general? So this slide is up here. I'm not going to go through all you have the slide, right? But the important point is that, these drugs are used often in our population. I mean, I'm a fly fisherman. Any other fly fishermen here? There's a connection. Okay. Well, I was pretty distressed. Usually when I go up on Poudre Creek and I'm fly fishing and I catch my trout and I release them, you try to take good care of the trout. Well, I was very dismayed to find out that in a lot of our rivers, we actually have sort of somewhat high levels of selective serotonin reuptake inhibitors. So these are sort of, the fish are actually taking up the SSRIs. So that's how sort of ubiquitous and almost universal they've become. But we've also learned over time, clinically, in using these drugs, that they have a lot of side effects. I'm not sure about in fish, but in people, these are some of the things we see, especially in older adults. And I've just sort of listed them here. Cardiac arrhythmia and even risk of sudden death with citalopram, prolonged QTC interval. How many people here have heard about that? They're really an important thing to be aware of, especially in older adults. But these are all the different symptoms. I've seen actually hyponatremia is something that is more common than I would have thought, just having read the literature. I don't know, Dr. Hirsch, how often you said, but, low sodium is not, I often will check sodium, especially if there's a reason to be worried about cognitive decline or other behavioral issues or medical issues in an older adult. So something to be aware of. What about cognitive enhancers, drugs like Aricept? And neuropsychiatric symptoms. So there is a literature out there that suggests that in people who receive cognitive enhancers, people with Alzheimer's, that overall they seem to do a little bit better behaviorally. And again, this is not a striking sort of effect. It's sort of a modest effect, but one that I think is probably significant overall. I think the important point here is that I don't use cognitive enhancers to treat behavioral problems. I use drugs like Aricept to treat the cognitive impairment that comes with Alzheimer's disease. But sometimes, if I might be inclined to also use a medication to treat depression, I might hold off on an antidepressant or something else and see if the behavioral problems actually improve just with the Aricept alone. So just one other possible benefit of of cognitive enhancers in people with Alzheimer's disease. And again, these drugs, and I don't know if Dr. Mungus mentioned this, but these are not, these are not silver bullets. I mean, they're not great drugs. We really need better drugs to treat Alzheimer's disease. So actually, when I teach medical students about Alzheimer's disease and care of people with Alzheimer's disease, I say that any day, if I had to choose between the drugs and good psychosocial treatments, I would choose the good psychosocial support for families far and above any medications to treat Alzheimer's disease. I think those are actually the most important modalities of treatment. But I also use cognitive enhancers in combination. This is just sort of from the JAMA study published a number of years ago, sort of showing this meta-analysis of the impact of cognitive enhancers on neuropsychiatric symptoms. And now I'd like to sort of move to the last topic, which is depression being common among caregivers of people with Alzheimer's disease. So this is sort of the last connection, right? And so, as we all know, caregiving to someone with Alzheimer's can be a very stressful experience. And I mentioned that those behavioral problems, that depression or agitation, aggression in the person with Alzheimer's is very stressful to the caregiver. And we now have a huge number of studies that show that caregivers are at increased risk for the experience of depression and anxiety. And that there are a number of interventions that I think are very helpful to reduce depressive symptoms in Alzheimer's caregivers and are very important when you're caring for a patient with Alzheimer's, is also attending to the needs of the caregiver. So what about some of the adverse effects of caregiving to somebody with Alzheimer's? There's stress. There actually is some emerging literature that suggests that caregiving to somebody with Alzheimer's may be associated with some increased risk of cognitive decline in the caregiver themselves. And actually it kind of makes sense in terms of some of the mechanisms we talked about earlier, depression being a risk factor for cognitive decline. And so I think this is sort of yet one more really important reason for doing all we can in clinical practice to support caregivers, to give them the skills and support to deal with what is often a very stressful situation. So impaired immune functioning, worse physical illness. Also family conflict is a very common, effect of or thing that caregivers have to deal with when they're caring for somebody with Alzheimer's disease. I see this again and again, that it's, it creates a lot of tensions and problems within the family. So, I could give a whole nother lecture about what I think is generally the not very good job we do of giving care to people with Alzheimer's and their family caregivers in primary care practice, but maybe that would be a topic for another talk. This is a study, so there's one of many. This is published in 2011, a study comparing depression in Alzheimer's disease caregivers and non-caregivers. And they took 125 Alzheimer's disease caregivers and 60 matched non-caregivers, and they found that 40% of the caregivers had significant clinical depression and only 5% of the non-caregivers. 25% of the caregivers of people with Alzheimer's disease were actually on antidepressants, but 2/3 of them still had significant depressive symptoms. And the caregivers had multiple stressors and fewer coping resources compared with the non-caregivers. One thing I'd like to point out here is this 25% of caregivers being on antidepressants, but 2/3 still with significant depressive symptoms. I would say that's not unique to depressed caregivers of people with Alzheimer's disease, but if you go into a sort of your average primary care practice and take older adults who have depression, who are on antidepressants, I would say that the majority of them will still have really significant depressive symptoms. So I think what's not happening in clinical care is we're not using, and I'll talk about this a little bit later, sort of a stepped care approach to the treatment of depression. So we're getting better and better in primary care of recognizing depression, and maybe people are reaching out for help, earlier. But what tends to happen is that people get placed on antidepressants and, 20 milligrams of Prozac or citalopram, and that's kind of it. And there's no change. Things just kind of, there's not aggressive treatment or monitoring of that depression. after the point of initial diagnosis and treatment. And so I think that's where we really have to sort of improve things in terms of the care for depression from a sort of public health perspective. So what are some strategies for caregivers to help them be less depressed? Well, one thing is information. It's remarkable to me, still in primary care, when people get diagnosed with dementia or Alzheimer's disease, and that's where most people receive that diagnosis, how little information the caregivers still receive about supports in the community, or even about the fact that when somebody has Alzheimer's disease, that it's very likely that they'll also have behavioral problems. We did a study of Latino caregivers of elderly with dementia, and we actually asked them, many of them were caring for elderly in the community, Latino elderly in the community with Alzheimer's who had high levels of behavioral problems. And so we asked them, have you actually sought help for these behavioral problems in the person you're caring for in primary care? And actually, somewhat to my surprise, more than half said, yeah, I've talked with my husband's primary care provider about this depression or agitation or something else. And then we asked, well, how many of you need additional professional help to manage this? And the vast majority said, yeah, we definitely need more help. Now, when we asked them, what kind of help do you need? Now, as a geriatric psychiatrist, I was very dismayed that I think one person said, what we need is medication. That's the help that I need. The vast majority of people said what we really need is more information and counseling about the disease. So I think that's where some of the biggest gaps are right now in terms of primary care management. So we need to give caregivers better skills to sort of deal with some of these really difficult Alzheimer's disease symptoms. Places like the Alzheimer's Association can be wonderful resources. They have free programs that actually teach caregivers how to better cope with behavioral problems, as well as support groups. There are also ways in which caregivers can maybe take better care of themselves. Something I don't know if it's on the final slide here that's about treatment for depression, but has anyone here, many people probably have, heard about sort of mindfulness-based treatments? How many people here have sort of heard of that? So actually, those have been shown to be a really wonderful treatment for anxiety. And anxiety is very common in people who are caregiving to somebody with Alzheimer's disease. And I think that's something we should, like a modality of treatment, we should really be promoting to help caregivers as well as sort of people in general who have anxiety disorders. I mentioned maximizing pleasurable activities and certainly treatment for clinical depression for caregivers so they can get their own treatment. So this is the uplifting slide here. Okay, now I see everybody's kind of getting dragged down a little bit. It's like it's like my daughter. My 14-year-old daughter. She saw this PowerPoint presentation that I was going to give today, and it said, Alzheimer's and depression. What's the connection? And she said, Dad, the connection is that's a really depressing talk. And so I said, okay, honey, I'm going to put in a really this is the uplifting slide right here, see? But actually, there's a point to this, right? The point is that, things like exercise, and mindfulness meditation and other things can really be helpful in relieving stress associated with caregiving. And I wanted in this final slide, before we go back to the case, and I tell you what happened to Dr. Smith, I wanted to just tell you a little bit about sort of the treatment of depression. I think it's really important for people who have depression to be treated using a real biopsychosocial model. Medications are not the single answer to depression. We really need to look at medical causes, medications, medical conditions, psychological aspects, the social contextual issues. So a well-rounded, holistic approach to the treatment of this condition. There are a number of different psychotherapies that have been shown to be quite effective. Some, perhaps arguably even better than medications for people with mild to even moderate depression. Cognitive behavioral therapy. Problem-solving therapy. Anybody here heard of problem-solving therapy? So actually that was what was used in a big study called IMPACT. which is the largest effectiveness trial for the treatment of clinical depression in primary care settings, sort of integrating mental health treatment into primary care for the treatment of depression in older adults. And they use both medications and problem-solving therapy. Problem-solving therapy is very much focused on the here and now, trying to help people develop plans to deal with those stressful things in their lives. And that was found to be quite effective, as effective as medications for the treatment of depression, and quite good in combination with medications in primary care. So behavioral activation, getting people more activated, more socially engaged, exercising. Medications, again, the best data we have now about how effective medications are for people with depression in your average primary care setting. Well, it's about 50% of people experience a significant improvement. But even among the 50% who are significantly improved, a fair number of them continue to have some depressive symptoms. So the depression is not all the way sort of gone. And a significant number, maybe as many as half, do not experience significant relief with medications alone. So I'm a big advocate for what's called stepped care and combined treatment. That I think, first of all, if you get treatment for depression, I think what's really important is to work together with your doctor to monitor that over time and be aggressive about changing the plan of treatment if things are not improving. One of the things I do in clinical care with the vets that I see, I actually hand out a screening instrument called the PHQ-9, which is available online. It's a screening instrument for depression. You can actually track your own depressive symptoms using that checklist and sort of monitor that and advocate for yourself in primary care if your doctor's not making changes in treatment. And really advocate for more than medications, for access to some of these non-pharmacologic treatments that are really important. So step care is critical. Now, we just have a few minutes left. I've got according to my clock, I've got 13 minutes. I hope that's accurate. No, Dr. Hirsch says that's not accurate. How many minutes do I have, Dr. Hirsch? 5 to 10. Okay, well, I want to tell you what happened with Dr. Smith. So anybody have an idea? So this is actually a real case. Now, I've embellished it just a little bit, but anybody see what really is sort of the root cause of his problem? Now, Dr. Hirsch is not allowed to I'm sorry? Raise your hand. I think I heard some good thoughts there. Yes. Medication. What's wrong with his medications? I'm sorry? And what combination? What could be wrong with these medications?
Remember your polypharmacy talk.
No, you're absolutely, so I just want to say that this is real evidence that the mini medical school is working. And you're exactly right, it was medications, and I'll tell you how. When I give this talk to medical students, it takes them literally 5 to 10 minutes before they come up with the answer, which is medications. And so this is actually a family friend. He called me on the phone. He said, look, he was really depressed. He said, look, I've got Alzheimer's. This is a guy who's extremely high functioning. And the first thing I did is I said, look, you've been on this Elavil for your fibromyalgia, for pain, and that has some bad effects on memory. And in addition, you're on this Paxil that has anticholinergic effects. You need to talk with your doctor about trying to taper off of these medications and see what happens to your memory. And he did that. And within 2 months, he was actually back to his baseline. No problems with memory. He was doing actually quite well. In fact, he was so grateful that about a month later, I received this package. It was actually a whole case of cigars. That's what he gave me. So I was not his doctor, so I guess he decided he wanted to increase my risk for cognitive decline. But that's what I got. And so that's what happened. And so actually there's a great scale. I know the Beers criteria are wonderful. There's actually a great scale called the Anticholinergic Burden Scale. It's out of the University of Indiana. And it has a list of all the medications that have anticholinergic properties. And that was exactly what was going on with this guy. So I'm going to stop there and take just a couple of questions. But yes, right here. Right in the middle? Uh-huh. I'm sure someone who has their hand... okay, you're going to pass the microphone around.
So do you approach your doctor who says that it's working for your primary thing that I'm seeing you for? We're not going to change your medications. I know that, we talked about the beer scale earlier, but how do you approach these doctors who feel they know exactly the thing that needs to be done for whatever your condition is?
Well, I think the first step is to have that conversation. I think if you feel like you're not getting anywhere, you're not happy with sort of the result of that, I think it's reasonable to get a consultation elsewhere from someone else. And, sometimes, I don't know what the issue was, but say if it's a cognitive issue, maybe it makes sense to, if you're not seeing a geriatrician, maybe to talk with a geriatrician or a geriatric psychiatrist or a behavioral neurologist and just get sort of a separate evaluation. So, I'm a big advocate. I think most people have good primary care doctors, and I'm a real advocate for trying to work this out with your doctor. Bring in some literature and say, look, I came across this on the internet. What do you think? Maybe we should try changing some of my medications and being a real advocate for yourself or for your family member. But I think if you don't feel like you're getting what you need to get out of that relationship, you need to try maybe another avenue, a consultation or something with somebody else. So that's what I would do.
Okay, I had a question about the last thing you said at the end of your lecture that was coming out of Indiana about the drugs that affect your memory or could affect your memory.
I'm sorry, say that again.
I didn't hear enough to write down what you said, the last thing in your lecture about the list of drugs that could affect your memory.
Yes, so there. Well, you had that lecture on polypharmacy, and I'm sure that it mentioned drugs that have anticholinergic properties. But there's also I don't know if Dr. Hirsch mentioned this, but there's a scale called the anticholinergic burden scale. And actually there's a group at the University of Indiana who puts that out. You can get a copy on the internet. And it actually has all the medications that have anticholinergic effects. And I think what's really kind of tricky and sometimes a little bit subtle about this is that you may go through that list and say, well, the ones that they say have really, bad sort of anticholinergic effects, I'm not on those, but maybe you're on 5 or 6 of these that have mild anticholinergic effects. And if you add up the burden, that anticholinergic burden across those, it's actually pretty significant. And then that can lead to memory impairment. I mean, I have seen other cases of people who tragically went for years, literally, being diagnosed with dementia and thinking that they had Alzheimer's disease before it was really discovered that really it was more of a medication effect. And once the medications were removed, they were no longer demented. I mean, that's rare, but it does happen. I've come across a few people like that. So
this is a question about learning to be a good caregiver. Who in our area is developing classes beyond this on being a good caregiver? If you are good at your job, you will suffer less stress.
A caregiver. So some resources. A couple of different things. The Alzheimer's Association has a number of courses that you can take that actually train caregivers, give them better skills to manage behavioral problems, etc. So that would be one resource. There are also support groups through the Alzheimer's Association and other places where you can actually learn from other people who are in your same situation. And I'm a big advocate for sort of peer learning. I think you can learn often a lot from other people who are going through something similar to what you are. The other thing that I always recommend to caregivers whenever I'm treating somebody with Alzheimer's disease in primary care is websites. The Alzheimer's Association, www.alz.org, has a lot of resources on their website. There's a wonderful book called The 36-Hour Day. That still is, I think it was published 25 years ago, and it still is sort of maybe the single best resource book for caregivers. So that's something that, those are some things I would recommend for you.
Another question over here.
Given that we know that what caregivers of people with Alzheimer's disease and other chronic conditions really want is psychosocial support and access to resources and information, how is primary care responding to maybe get care coordination for patients so that they can get those kinds of resources?
That's a great question. Just sort of a comment, I think that unfortunately as a country when it comes to sort of mental health care, I think medications have been a bit oversold. And they're very appealing because they do work. I mean, don't get me wrong, they definitely have their place. But I think there's too much reliance on medications. And I think one of the trends that's been ongoing for 10 or 20 years now is the integration of mental health services into primary care. And I think that that's happening in primary care clinics. I think as part of the medical home, sort of that concept, you have sort of the integration of different services. So I think that's where it's occurring. And I think that for conditions like depression or dementia, that's what we really need in larger primary care clinics, is we need, and maybe it's not the doctor who does that psychosocial treatment, but maybe you have somebody else, a nurse or social worker or someone else who can help work with the family and deliver that. But I think it's a key issue for our country. And I also think that it is something that drives up healthcare costs. And it drives it up not for, I think what ends up happening is that basically, and I published a study that were basically interviews with primary care physicians we published about 5 or 6 years ago. And basically it's that people, the way that one primary care physician put it, is that people with Alzheimer's disease create chaos in the primary healthcare system. Or they do once they develop behavioral problems and agitation, etc. And then what happens is that person, it goes on a trajectory in which they become institutionalized. And so it would have cost more money sort of up front. There would have been cost entailed with developing psychosocial treatments so that those behavioral problems could be better managed before the behavioral problems became severe. But as a society, there are enormous costs, downstream costs from institutionalization, et cetera. So I think it's a great question and a great point. So we have to, I think that we're making progress, but we have a lot more to do in terms of integrating these services into primary care settings.
Thank you very much.